The report before you is a legislated requirement under Regulation 267 or 257 of the Ambulance Act, and it's Regulation 26708, and it's the response time plan for Essex-Windsor EMS. Within the background, it tells you, in the report, it tells you that we have to develop it annually, ensure that it's continually maintained, provide a plan and update to the ministry, which we have to do by October 31st, and report to the ministry our response time performance. On page 2 of the report, there's 2 key indicators that we must meet, and they are a legislated requirement, and that is the 6 minutes for sudden cardiac arrest, and that's a notification of a call of an ambulance and to the time that a defibrillator gets to the patient's side, and the other one is CTAS level 1s within 8 minutes, and that is when EMS arrives on scene. Those 2 are defined, and within the report you'll see the other minute times are at the discretion of council and approval. I do have to explain, and I know all of you have heard this before over the years, Canadian Triage Acuity Scale, or CTAS levels, and they speak about resuscitative, so that's the most life or limb type of call. CTAS 2 is emergent. These could be life or limb, and they could go to that effect. And to put it into a visual, a CTAS 1 and a CTAS 2 are normally transported by the ambulance with lights and sirens. You get to the CTAS 3s and the CTAS 4s and 5s. Those are the urgent, less urgent, and basically non-urgent type of call that we may transport a patient to a hospital. A lot of people get confused with the ambulance priority coding system. It's converse to the CTAS. So code 1 is a deferrable transfer. A code 2 is a scheduled transfer. Code 3 call is a prompt response, meaning that we can't delay it, but we don't travel lights and siren. And then a code 4 is urgent or emergent, and we travel with lights and siren. So before you tonight is the response time standard plan that was basically developed back in 2012. And at that time, we looked at a whole bunch of different things, but we found that there was difficulty in assessing, and these difficulties still stay today. So some inconsistent data through the ambulance dispatch record system, limited data availability for defibrillator equipped arrival times. This can include both fire, tiered response, or public access defibrillation. Deployment plan strategies and adjustments. We really started to refine those in the last 2 or 3 years with diversion protocols and different types of adjustments to our deployment plan. And then the response time standard is based on a CTAS category, regardless of what dispatch may assign as a response priority. So if you can imagine, if they don't get the information correct or don't receive the correct information and dispatch us out on a prompt response, no lights and siren, but find out it's a CTAS level 1, it will skew the data largely. The other thing is, under the legislation, we're mandated to do it on a global or a regional perspective, so through Windsor and Essex County, and it's not drilled down by each municipality, and understanding it that way. Continuing impacts are noted in the global pandemic, COVID-19. I know you're really getting tired of me saying this all the time, but COVID-19 has impacted the response times with increased offload delays, both in quantity and duration, decreased capacity within hospitals. The hospitals are quite full, and I can't talk about that tonight. Over the last 36 hours, we've been really strained on getting our ambulances offloaded at all 3 emergency departments. Decreased person-to-person access to primary care has impacted us on our response times. Increased use of emergency rooms for low acuity healthcare, increased backlog of healthcare follow-up and treatment, and decreased human resource across the healthcare system. Whether it be a paramedic or a nurse or a doctor or a respiratory therapist, the human resource is being depleted. But given the many variables, we have done the review, and I look back at it through 2017 all the way through to 2021, January to September. And there are some anomalies that I will discuss tonight for 2020 and 2021, the most being the pandemic and how it's impacted. So the chart on page 6 of my report talks about sudden cardiac arrest, and our target is 6 minutes, 55% of the time. And you'll see through the analysis all the way through that we didn't meet the targets for sudden cardiac arrest through to CTAS level 5. And the basic reason for that is pressures through the pandemic, offload delays, and hospital capacity. But what has to be noticed, though, is if you go back through 2017 and all the way through to 2020, we were making great achievements. But the anomaly of being the pandemic lowered that in 2021. I expect that as we come out of the pandemic across all of the levels, from sudden cardiac arrest all the way through to CTAS 4s and 5s, we will see a return back to previous experience. Unfortunately, in 2021, we're experiencing this on a daily basis. The action plans that we've put in place, we continue to put in place, is number one, the offload diversion protocol, where CTAS level 4s and 5s, as the capacities fill up across the emergency departments, we divert to a facility such as Erie Shores and Leamington that has the capacity to accept and treat a patient in those lower acuity levels, and then divert patients to Windsor for cardiac problems, trauma, mental health. The vulnerable patient enrollment in community paramedicine and remote patient monitoring since 2018 has done great benefits, both from the Ministry of Health investing in it and, more importantly, County Council investing in it both in 2018 and last year. With that, we've reduced the usage of emergency services, and that's helped improve response times, but not through 2021. But we're going to continue that moving forward. Offload management, patient flow planning. Today, I can say, as a prime example, both myself and all my deputy chiefs were on phone calls and emails all day long, trying to manage the flow of getting across. Over the past 36 hours, it has been difficult. I can say, by looking at my dashboard right now, we are somewhat back to normal, but I'm very cautious of how that's going to work. We do our deployment plan monitoring adjustments. As a prime example, even today, I've advocated with the Ministry of Health to see about doing offload delays and what they're going to do to help us with that, because across the province, we're seeing that issue elevate. Determining the call volume impacts, unit hour utilization rates, and pressure service-wide determine the need for the service moving forward, and utilizing the master plan of 2018. So with that, before you, the recommendation is proposing the response time standard presented below be approved. It hasn't changed. It continues to be the same of sudden cardiac arrest in 6 minutes, 55% of the time. CTAS 1, 8 minutes, 75% of the time. CTAS 2, 10 minutes, 90%. CTAS 3, 12 minutes, 90%. CTAS 4s and 5s, 14 minutes, 90%. They remain unchanged, I admit that, but they have worked in previous years, and I think we get through 2021 into 2022, we'll see that everything will be back. They are achievable standards. They meet the historic response time needs. So with that, we have no financial implications with this report, but the recommendation before you is that County Council authorize administration to adopt and submit the proposed 2022 Essex-Windsor EMS response time performance plan as required under Regulation 257-00, as amended by Regulation 267/08. And with that, Warden, I'd be welcome to take any questions or comments.
All right, thank you very much, Chief. Any questions or comments to the Chief at this stage? No comments. Yes, Mayor Bondi.
Thank you, Warden. Thanks, Chief Krauter, for the your report. It seems like you could have the best team in the world, but with the offload delays and then service levels of personnel, it's out of your control. So I see this report and I read it and I go, it doesn't matter what he does, you can't change it unless the Ministry of Health helps you out with more staffing in the hospitals and decrease your offload delays. So appreciate the report, and I'll move the recommendation.
Okay, move and supported by Deputy Mayor Joe Becchetti. Just a couple of, go ahead, Richard. I'll defer to you. Go ahead.
Yeah, I just want to make a comment here. I got to say thank you, Chief Krauter, for presenting similar standards to the previous year. I know it would have been an easy way to get them down lower is to, to say to us, we can't see this.
You're frozen there, Deputy Mayor. Okay, we lost the Deputy Mayor until he comes back. Just a comment and a question. Chief, when you look at, you kept referring to COVID-19. We know that's been with 22,000 cases so far, and certainly that's been, the travel to the hospital has been increased dramatically. But what impact as well, because we've seen that mental health has been a huge increase, opioid crisis in our region, huge increases, and how much, or I don't know if you're able to tell us, but how much time that takes, to offload those patients as well, because that you've got really like three pillars here that are really affecting. I guess the offload piece would be mental health, the opioid crisis, and COVID.
Yeah, so thank you, Warden, and through you to the rest of the County Council. Mental health attributes about 10 to 15% of our call volume. And for the majority, those are a low acuity, so CTAS 3, 4s, or 5s. So when they go into the emergency room, very important that they go, they don't get the emergent, so they don't necessarily come off of our beds right away. And there is limited resources within the emergency departments. This week, sorry, I'm kind of looking like Mayor Snively. This week, the announcement from the Premier about Hotel du Grace becoming the center of excellence for mental health. That's news that's very much welcome, that if we can get that going, because that will help us out tremendously of getting mental health patients to the right care at the right time. But right now, it is a pressure, because once the only site that takes mental health patients is Olette campus, that also takes trauma and takes stroke and cardiac patients. So it becomes a funnel and it becomes a plug. And that's where we have our difficulty offloading. The opioids crisis, that is another one that takes up resources. And with naloxone and Narcan, we still have to go. Sometimes we transport, but with Narcan, people wake up and they may refuse our service, but it still takes a lot of our resources. So I appreciate the question. I hope I've answered it. But it does take a lot. But we are working, for example, last year we got approved for our mental health and response team. We're getting that up and moving, that we want to get the care into the street and get those people directed to the right care, not necessarily the emergency department, but if there's a service at Hotel du Grace or CMHA or the transitional site, they get the right care at the right time, and then it decreases our volume overall.
Okay. I see Deputy Mayor Meloche is back. And so I'll turn it back to you.
Thank you. Haven't lost my internet all night long, and then when I'm speaking, I lose it. So I just want to mention to Chief Krauter that it takes a lot of commitment to be able to commit to the same numbers as this year, when it would have been so easy to come to us and say, hey, look, I can't predict that these numbers are going to get better. I think we should lower these standards and so on. So I got to commend you on this, Chief Krauter. Thanks for being so committed to making sure that we're safe here in the community. I know it's not a difficult job. I know it's a difficult job. And you and I have had many conversations in recent times with regard to black codes, red codes, being understaffed or claims of being understaffed anyway. But thank you for continuing on this effort and giving us what you think is really the way it should be for next year. So I'm excited about this. Thanks.
Thank you, Mayor Walsh.
All right, any further questions or comments? Yes, Mayor Snively.
Yes, through you, Warden. again, to Chief Krauter, I want to thank you, Chief, for giving me the updates today on some of the questions I asked you. I know we had one of our counselor members had concerns, and I'm glad you addressed that. And I like what I'm seeing here on the screen, okay, which is good. One question I've got for you, mental health. The numbers for mental health, are they really on the rise right now from year to year because of COVID?
They're on the rise, yes, with COVID, but they've been on the rise over probably the last 4 or 5 years with mental health. And one of the reasons is the low amount of resources within the community, and those have been improving. And you can see from, I'm sure from your police commissions, when you meet with them, you'll see that the police are struggling with mental health calls and responses. EMS is dealing with the same thing, and the hospitals are. Like I said, it's 15% of our call volume, and it seems to be going up every year. And again, I want to point back to the announcement earlier this week from the Premier of Hotel Dieu Grace being a center of excellence. I think that's going to be a game changer for mental health in our region. And I look forward to working with that group and Jan Caffer and all of her team on how we can work as a collaborative to get the right care at the right time.
Okay, once again, thank you very much, Chief.
Thank you, Mary Snow.
All right, any further questions or comments to the chief? Just one question, Chief. I know, there's been, some noise being made about, one patient and a long-term care facility, and maybe you can elaborate a little bit, the protocol and certainly it's always difficult to lose a patient, regardless of what age and illness they have. But I know that there's been, noise in some of the media outlets and social media, but I think there's no better person than yourself as a chief that really understands the ins and outs of EMS protocols.
Yeah, thank you, Warden, and through you, the County Council. I'm looking over at Ms. Birch right now as our privacy officer, and I'm going to have to deal with this very delicately due to personal health information, and I cannot divulge anything about any type of calls that we did, and I'm hoping that Council respects that and understands it. But I can say that when we are limited in resources, we do get to a point that we triage calls as they come in. And sometimes patients or callers that are requesting ambulance services may have to wait. For example, if you look at the report on CTAS 3s or code 3s, they are triaged by the dispatch center, and in level of acuity, they may go into a queue and wait to be responded to, because we want to keep our ambulances available for the most serious life and limb. In some cases, there may be a lengthy delay, and the dispatch center calls back regularly. I believe they're controlled by the province. They call back every 30 minutes to get updates. If the update changes, an ambulance is responded to immediately. So if it goes to a dire life or limb, an ambulance responds and treats that patient accordingly. And we deal with that in a way of how the patient wishes, how a facility wishes, and all of that. I'm sorry that I can't get into more of what the call did occur or what may be on social media, but I have to be very cognizant of personal health information and how I can release it, especially in an open forum.
Yeah, and I certainly appreciate that. But I think the point made is that the protocols that are in place are taken very, very seriously. And it's not like a one-off. There are protocols, and it's followed up on an ongoing basis. And I think that was the point. I think that certainly I wanted you to make, and that there's a lot that goes into it. And sometimes when you read stuff in social media and that, there's a lot of gaps, and people don't understand all of the efforts that go in by EMS and all the personnel and all the protocols and it's quite a procedure to follow.
Yes, it's a very extensive procedure. On any time that we delay a response of an ambulance, it's a very extensive procedure of how we do it. We don't take it lightly. We don't want to do it, but we have to keep the insurance policy of having the ambulances for life or limb emergencies. And I'm not downgrading the other ones, but it's for those.
Well, this is why you have all the different codes.
Yep.
Okay, thank you. It's been duly moved, supported. Any further questions or comments? Hearing none. All in favor? Opposed, if any? That is carried.
Thank you.